It's Conrad Ivie here. I'm one of our hip and knee specialists at Tennessee Orthopaedc Clinics. And today what we're going to talk about is we're going to talk about hip pain. We're going to talk about the causes, treatment, and then some of our hip treatment and preservation options we have. If anybody has questions, oh, I am muted. Sorry.
Dr. Ivie, you're good. I can hear you.
I'm muted. I got to unmute myself.
You're good, Dr. Ivie. I can hear you.
Okay. So if anybody has any questions, please stop me because, and just type that in the chat box, because that'll be the easiest way to kind of keep up with things, because I know people will have things that pop up as we go through this, okay? So as we look at the hip, we're going to kind of go through some anatomy first, just to show the different areas that people can hurt around the hip, because a lot of questions come from that. And then we're going to go through each one of these areas and the treatment options with different things as we go. First off, the most common things around the hip to hurt are people's, as we look at bones. So when we look at bones, we're talking about the bones in the spine and the sacrum, as you look here. We got the ilium. That's kind of the big bone where your hip sits. As far as when you look at where your belt sits around your hip, it sets across your ilium. And then you've got the real hip joint, which is down here, and that's the ball and socket of the hip joint. We then have the muscles around the hip. As you look at the muscles that directly interact with hip movement, there are over 17 muscles and up to about 21 muscles, depending on the anatomic study that's looking at it, that contribute to hip motion. You also have the intra-articular portion of the hip, which is this ball and socket. The other things you have in here are the labrum. You have ligamentous attachments here in the socket, and then all the way around the capsule itself has multiple ligaments in it. All of these things are things that can give you hip pain. When we talk about hip pain, it's easiest to kind of look at this about where it hurts. So when people come in to complain about hip pain and just try to communicate with us as physicians where their pain is, one of the first questions we ask is where it hurts. And when we look at diagnosis of common problems and treatment options, we find that the history of it is probably the most important thing. The people are very good at telling us where the problem is just based on their history. And so where you point to your pain, how long it's been going on, what makes it better, what makes it worse, those things are very important as far as making sure that we have the right diagnosis. So I really classify pain around the hip into about 3 major areas. You have posterior pain, which is in your gluteal area. You have the lateral pain, that's the pain on the side of your hip when you like lay on your side and that hurts. And then you have anterior pain, which we would consider like groin type pain. All 3 of these correlate to different problems that can occur around the hip. We're going to talk about conservative treatment options and surgical treatment options, but just to kind of go through them, because I will list them multiple times through here as we talk about different hip problems. We have our very conservative basics where we start is rest, ice, compression, elevation. It's a little more difficult to elevate a hip, but there are some positions that are comfortable for people with hip pain. One of those positions is a recliner position. So often people with hip problems and even some back problems find that sleeping in a recliner or getting in a recliner position to rest is very effective. Physical therapy. Physical therapy is one of our conservative options to work with people to really strengthen the muscles and work on the mobility around the hip or a back. Anti-inflammatories like Aleve, ibuprofen, other anti-inflammatories that we can call in like Celebrex or Meloxicam. They're all different options of anti-inflammatories that we can prescribe patients. And that's really just to decrease pain and inflammation. That's their main thing there. There are also some natural anti-inflammatories like curcumin and some other things where people want to try to avoid the prescription anti-inflammatories that you can try to take supplements as well. When I talk about injections, we typically describe an injection as a cortisone injection. So that would be an injection of a numbing medicine and a steroid into the area that we're treating to try to calm down the inflammation and pain in that area. We also have things like platelet-rich plasma, which is where we take a patient's blood, we spin it down, and then we get the healing factors off the top of that. That's the platelets and the plasma that have the healing factors in them, and then we inject that back into the spot that's hurting patients. And for some of these problems, those are actually very good. And then, of course, our last resort is always surgery. Given in here, just one other comment would be the scale is in there because of weight loss. And while it's not the easiest thing to do when your hip is bothering you, we do have a lot of patients that just losing 10 pounds can have significant results for your hip, because your hip sees 4 to 6 times your body weight with just normal activities. So if you lose 10 pounds, it feels like to your hip that you've lost 40 pounds. So we're going to start with posterior related pain. It's more in the gluteal or posterior gluteal area. And when we talk about posterior pain, main things that when you come in talking about that, the first things that we're kind of looking at, hamstring pain, sacroiliac joint pain, and then low back pain or sciatica. When we talk about the hamstring, there are two types of hamstring tears. There tends to be more acute tears. That's what you see a lot in athletes. It's posterior pain. It's on the bones where you feel like you sit, the sit bones or the ischium. A lot of people will feel a pop, and then it hurts to sit down and have pressure on that area. There are two muscles that attach right here at the ischium that can be torn that cause that pain. The first treatment for most all of these problems is going to be rest, ice, and then therapy. It takes about 6 weeks for these problems to heal and really start where you're getting better with that. Occasionally, we can put PRP injections in this area, and very rarely does this equate to surgery. When we talk about surgical tears, they tend to be something when it's a very acute tear, and it's really only in high-end athletes that we're really trying to do a lot of hamstring repairs, because the surgery itself has a difficult healing and a lot of stiffness for people afterwards. Next, we're going to talk about the sacroiliac joint. This is the joint where your spine comes down and joins with your pelvis. So your sacrum is the very bottom portion of your spine. And you can see that area here. This is the sacrum. And then this is the ilium up here. And the sacroiliac joint is right here. Again, we're talking about posterior related pain. This pain is just off the midline and the posterior aspect of the leg. A lot of people have trouble still sitting with this. A lot of people will describe that if they tighten their belt up, it helps them with relief for this at time. And then the test for this is when you look at it is this figure 4 test. And so when people are having problems and we're trying to rule out that SI joint, this figure 4 test kind of gives us that indication that, yeah, we think your SI joint is flared up or inflamed. Again, with treatment, we start very conservative with ice, compression, physical therapy. There are some compression belts that have helped people. Physical therapy is going to work to strengthen the muscles up around the hip and the back to try to help the pain. Injections, we can do injections under fluoroscopy with some of our injection suites where we can do that here in the clinic. And then we also occasionally will have things go to surgery. That's typically done by a spine surgeon because they are going to go in and fuse that joint. We also think about low back pain. So low back pain or sciatica kind of run together. It can radiate down the legs, but most of the pain in the low back is going to be just musculoskeletal pain in the low back, typically a muscle strain that is going to get better in about 6 weeks or so. That's why the treatment for low back pain has always been very conservative to start. Again, it's the RICE and the NSAIDs, physical therapy. And then typically if those things aren't fixing it, we're talking about getting an MRI and having somebody see a spine specialist for either injections or discussion of other treatment options. So now we're getting into more hip-related pain and hip symptoms, things that we can really do some things about for the hip and knee specialty world. And so now we're talking about lateral-sided pain. When we talk about lateral pain, there are multiple things, but this is kind of this area on the outside of your hip. Typically, people will say, it hurts me at night. It hurts to lay on my side. I'm a side sleeper, and I find I have to turn back and forth a lot to really get relief from the symptoms. They tend to be pinpoint tender out here, right on that bone that you feel on the side of your hip. Motion-wise, a lot of people have trouble with this. Sitting and standing tends to be going from sitting to standing is one of those areas that hurt. Some people will have difficulty with their gait, where they feel like they have a significant limp, where their pelvis will tilt as they walk. And what we're really looking at are these muscles out here. You can have the IT band and things bother you, but the two key muscles, are the rotator cuff muscles of the hip, are the gluteus medius and gluteus minimus. And so when we talk about an abductor tendon tear, that's what we're looking at there. Typically, treatment for this pain on the side of the hip is going to start very conservative. We will tend to start with anti-inflammatories and compression, physical therapy, injections like cortisone or PRP are the normal treatments for this. The difference is, I will say, one area that we've gotten a lot better in this is when people are having the limping, or when it's acute, we tend to look more at what's going on and go straight to MRI more often. The reason being is I see an increasing number of abductor tendon tears, or these rotator cuff muscle tears in patients. And when they have recurrent symptoms of IT band pain or difficulty there, or they have these tears and that limp, it makes us think about things that we should surgically repair. So we tend to get MRIs a little earlier in patients with that kind of pain if they're having significant gait abnormalities. To kind of look at what we're doing in an abductor tendon repair, I do these arthroscopically, which has been a big change for patients. This used to be mainly an open procedure. And as technology's evolved and we've gotten better, we've gotten to where we can come in and arthroscopically repair these tears. So what we're looking at here in this first picture, this is a hip scope that we're using. And you're looking at this area, and that's where the tendons, the abductor tendons, should insert. They've pulled off of this area. This area is just now bone, and they are pulled off up here. So what we do is we go in there with the scope, and we put anchors into the bone, and then we come up and grab the tendon, and we repair it back down to where it should be. And so this is what it looks like after we've done one of our abductor tendon repairs. So it's holding those tendons down back to where they should be. The changes with this have been really great for patients. It's less invasive than open surgery. The recovery time, though, is a little slow. You're in a brace for about 6 weeks. You're protected weight bearing for 4 weeks, using crutches for those first 4 weeks. And we're really just giving it time and taking it slow for the first 3 months to allow these tendons to heal. We call these tendons the rotator cuff muscles of the hip because it does function very much the same as the shoulder does with its rotator cuff muscles. The last area of kind of pain that we classify in our main 3 areas is anterior hip pain, and this is more the intra-articular portion. There are a couple muscles here we'll talk about that can cause pain that are not really inside the hip joint, but typically when somebody complains of groin pain, we're talking about the intra-articular pain of the hip. The muscles that we commonly see associated with pain, number 1, this is our hip flexor muscle. So you see this muscle here is your iliopsoas muscle. It comes down and it inserts down here on the femur, but it lays over right at the front of the hip. So if somebody gets tendonitis in this area or a strain of the tendon in this area, they have pain. This commonly will occur getting in and out of a car is a common complaint as to why this hurts. And lifting the leg when laying flat and trying to lift your leg up in the air, that's another common test for seeing if this hurts. It's very conservative treatment. There's not a lot of surgery for this tendon and tendonitis in this area. And so we are very conservative. It's the anti-inflammatories, therapy. We can do injections, but typically that involves interventional radiology to get those done. And very rarely, but sometimes we will end up going in and releasing this tendon for people if they have chronic problems with it. Your adductor tendon is another tendon around your hip, and this is kind of the thigh master muscle. So when you think about when you're bringing your knees in against resistance, that's your adductor muscle. And those muscles, again, they insert up here in the pelvis, and they can cause groin pain. There's very few surgeries that we can really do for this, so we do mainly focus on the conservative treatments with this. Now we're going to talk about the intra-articular pain. And the main areas, the main three most common areas of pain for what's going on in the hip, as far as the joint itself and things we can do for them, would be hip impingement with labral tears, and then hip arthritis. There are multiple other things like instability and dysplasia and avascular necrosis. All these things do occur in the hip and are common, but they're not as common as these three. When we talk about hip impingement, it's an abnormal shape of the proximal femur and the socket or the acetabulum. And what happens is, in a normal hip, this is kind of a slice view, like kind of what you would see on an MRI of how we would evaluate this. But there's the ball, which is the femoral head here, and then there's the socket. And in some patients, they develop a little extra bone up here on the front of the socket, and we call that a cam, or on the front of the femur, we call that a cam lesion. While other patients will develop a little over coverage on the acetabulum, and we call that a pincer lesion. But we also see some people that have a little bit of both. A labral tear is when you get a tear in the labrum, which is this soft tissue that goes around the hip. So if you think about this as a ball in a socket, around the area out here is where the labrum is, and that creates the seal of the hip. So that if you just had a ball in a socket, it's really easy to move in and out of that. But if you have a seal created around it, it creates a negative pressure, so it really holds that ball in the socket well. It also has proprioceptive fibers, which tell your body where your hip is in space, and it has pain fibers as well. So when people get tears in this labrum, they can even be very small tears, but they can cause pretty significant pain. When we look at treatment of impingement and labral tears, we find that people come in, they kind of give us this C sign. It hurts all the way around their hip. And so they'll kind of give us this sign of it hurting all the way around their hip. They'll tell us this is our test to try to check for tears. This is what an MRI looks like with a labral tear here. It should be setting directly right there and look like a very round tubular structure. And instead you see that this patient has a labral tear, but also has, would be a cam lesion right here where there's a little too much bone. And what happens is that bone, when we bend our hip up and flex against here, it pins that labrum up against the acetabulum and causes pain. The difference is when we have hip impingement with a labral tear, the conservative treatments do not really work that well. The most recent study looking at this showed that patients with hip impingement and a labral tear with physical therapy versus just going straight to surgery, about 75% of the physical therapy group had transitioned to have surgery by the 6-month mark. So often with these cases, we are being a little more aggressive surgically because these things can cause a lot of pain in patients. When we try to work this up, it almost always includes an MRI to really make sure that we are able to see everything that we need to see, again, because it's mainly soft tissue, to know what's going on. The treatment for hip impingements, hip arthroscopy. I'm going to talk to you a couple of things here about hip arthroscopy. But the really neat things, sorry, there's a typo at the bottom of the screen, but the neat things that we have going on, traditionally, if you look on the right side of your screen, this was done on a table where there was a post in the perineum to kind of pull traction against the hip. What's really been a great thing that's developed over time is this new table that is now postless. It's all traction based. I used to do a lot of arthroscopy with this other table before I had the new one. And I can tell you my patients have noticed a drastic difference in using this new table to allow us to be more gentle with their hip and as well as their recovery. So we've seen a huge difference with that. Intra-op, when we're working on hip impingement, what I'm working on is the labrum, and we will go in and we will repair the labrum back to where it needs to go. But also it's a combination of things trying to treat the impingement. So We're using x-rays to make sure that we decompress things the most and that as the adequate amount. We combine the x-rays with this computer programming that we use to make sure that we've looked at the decompression and gotten the right amount there, as well as with the table, making sure that we're treating the hip the best we can. This is looking inside a hip scope, and this is looking at the labral tear. So when you look here on the left-hand side of the screen, there's the labrum that's up here, and this is the tear where the labrum's pulled away. And so this is very irritated and inflamed. And then what we do is we come in and we put sutures around it and kind of tie it back to where it needs to be and recreate that tubular structure of the labrum. Results of hip arthroscopy have been pretty phenomenal. This affects a lot of athletes. So we have a lot of athletes, but we have also a large number of people that get these later in life. And when we look at it, the return to sport at 6 months is about 91% of all athletes that we're working on. What does that translate to for most of us? It means that by 6 months, you're back to doing most activities you want to do. This area of orthopedics is very new. So when we look at it, we're expanding our literature and the amount of knowledge we have on this on a routine basis. So we found that while initially they found really poor results with people as they age, we're able to do this in people as they age more and more with better and better results. To whereas now, regardless of age, if we're looking at it and it's isolated labral pathology or hip impingement pathology and there's not significant arthritis, we're able to perform hip arthroscopy and give patients great results. The last area that we kind of talk about, this would not be preservation or keeping a hip anymore, but this is kind of the last phase of things we can do around the hip, is when we're talking about arthritis. When we talk about hip arthritis, what we're talking is when you look at the ball and the socket, you see the space in here, and that's where cartilage is. When we look at hip arthritis, you lose that cartilage, and it's just bone rubbing on bone. When it gets to that point of bone rubbing on bone and treating hip arthritis, the hip preservation options are no longer on the table. The reason is hip preservation trying to treat arthritis did very poorly. And so if we're trying to treat arthritis, we can't do a hip scope because patients ended up going on to a hip replacement at a very high rate within the first 2 years. So we want to be very conscious and never perform a surgery unless we really think it's going to fix the problem. So we do not treat hip arthritis with hip arthroscopy. When we look at arthritis, it's typically aching and stiff. A lot of patients will have that pain. Again, this is groin-related pain most of the time, but about 15% of the time for hip arthritis, it can be the lateral side of the hip or even posterior in the hip. We treat it conservatively with therapy, anti-inflammatories, cortisone injections. PRP injections do not work for arthritis, so we do not use those for arthritis. And then it does occasionally move on to surgery. When we look at surgery for the hip, it's a hip replacement. There's a lot of great things that we're able to do with hip replacement, and that's a whole nother talk that I could spend hours talking about. But when we look at it, the things that we have going for us, anterior approach, going in from the front of the hip, we don't cut any muscles. It makes recovery a lot faster. Patients really do phenomenal with that. And then the next area that really has expanded our ability to fine-tune how we really place these parts in there is robotics. So robotics with hip replacement have really helped us to make sure that the parts, the leg lengths, the offset, all these little things that we're trying to fine-tune in surgery have really improved with robotics. When we talk about robotics, planing, and hip replacement, we get a CT scan beforehand. We plan out where all the parts are before we've ever started the surgery. And so as we plan out that whole area, we know exactly where we're putting the parts before we ever get into surgery. Thus, it makes our outcomes even better and our precision even more accurate when we're talking about restoring offset and leg length. And this is what a hip replacement looks like in one of my patients. So people really do phenomenal with this surgery. As far as things, that's everything that we've kind of talked about. This here is just kind of again, just an overview for us. The QR code down at the bottom of the screen will actually link you. It will create a contact for you that gives you contact to my team. It's the email for Team Ivie. It's also the extension and phone number for my staff to take care of them, as well as our website page and all that. So if you scan that with your phone, it'll actually pull up a web link that you can then download our contact information. Any questions?
Thank you, Dr. Ivie. I see there's already a few questions in the chat box. If anybody has any additional ones, you can go ahead and put them there. Dr. Ivie, I'll just
pulling up the chat now.
Okay, perfect.
I'm sorry, it's a little late for me to fix the sound problem. I apologize for that. Bursitis. So when we talk about bursitis, that would classify in that lateral sided hip pain. So when we talk lateral hip pain, I'm talking bursitis, IT band tendonitis, and then the abductor tears. I'm sorry I didn't comment on that more, but I lumped those three kind of together because they all hurt in the same spot. So when we have hip bursitis, it's also very common to be in combination with that IT band tendonitis. So we start that treatment very conservatively. So if we come in, we're having lateral sided hip pain, it's been waking us up at night, really haven't done anything for it yet, but we're not limping too much, we're not needing a cane or anything like that, we will start very conservative. So we would start with physical therapy. Physical therapy, its job is to strengthen up those gluteal muscles, that gluteus medius and that gluteus minimus we talked about. Also to stretch out the IT band so it's not rubbing as much on that area. When we do that, typically the pain will resolve, but most patients, even when we do that, they're going to have to continue with those stretches and exercises long-term to kind of keep that bursitis at bay. We can do injections for bursitis, and that does help to calm it down. As I've done more abductor tendon repairs and I see more and more people for that, I use less injections in this area. So I really reserve injections for when it's really point tender, it really hurts, or when we have a really big trip or vacation coming up where we're trying to really not hurt during that time. So the next question says, I have SI joint pain and don't take NSAIDs. What are natural options we can use? The curcumins are one option. They're actually no consensus because we can't do studies on this because it's a separate area, and as a supplement, the FDA is not really controlling supplements really well. And so there are multiple natural supplements that you can look at to use for things. So curcumin is just one of them that's kind of at the top of the list of natural anti-inflammatories. We do get a lot of questions around glucosamine and chondroitin. And when we look at those things that people are taking that for, those are really building blocks for the joint fluid and the lubrication. And some patients do take those and have good relief. And others feel like they don't do much. When you look at the studies on it, we're kind of at the point where we think it's a very low risk to take it and it has benefit to some patients. So we recommend that if you want to try it, it's a good thing to try. The next question is, with a gluteus medius repair, is stiffness a common complication post-op as it can be with rotator cuff repair? Typically, no. And the reason is with rotator cuff repair, after surgery, to get the tendons to heal, they lock you in a brace here and hold your arm for 6 weeks or more sometimes to try to let that heal. It's really difficult to do that around the hip. We get around that by protecting our weight bearing and using a hip brace. But the hip really does phenomenally well at regaining its motion. So typically patients do not have difficulty with motion after a gluteus medius repair. The next question comes from Select PT at Strawberry Plains. Treatment options for obese, overweight patients with severe OA who are not candidates for a total hip. You mentioned a few supplements. Any other ideas? This is a really difficult area of patients for us to treat. And the reason being is there are some studies that came out that showed that certain BMI categories, as we get into the BMIs above 45 and even above 40, have increased risk of complications with surgery. That's equated to people being a little more selective and really trying to get people's weight down before surgery. As we try to do that, the difficulty is it hurts, and it's hard to do exercise when your hip hurts. And so looking at ideas of things we can do, the exercise and physical therapy options, really aqua therapy is one of the best things for these patients to try to help them lose weight. I would recommend more of a, when we're trying to get weight, kind of my go-to things. I tell people not to consume calories via liquid. So if you're drinking something and it has calories in it, to get away from that, I recommend eliminating all sodas, just because there's some, when you even look at diet sodas, diet drinks do trigger your body to store fat because it gets a signal that there's a sweet taste. So you do get that signal, and it does equate to patients storing more fat. So that does not help with weight loss. Any exercise we can get is the best thing we can, I would prefer us to do and stay active as much as we can. But the last thing I kind of tell patients is the best way to really work with this, or one of the easiest ways I've found, is to really only eat foods that your great-grandparents would recognize. So eliminate all the highly processed things in the center of the grocery store and go back and eat the foods that your great-grandparents would recognize. And if you do that, it eliminates a lot of these things that have a lot of inflammatory factors in them. And then also, it's hard to consume too many calories when you're eating just unprocessed meat that you had to cook yourself. When you're eating fruits and vegetables, it's really hard to consume too many calories. It's hard to do that. I've done it off and on at different times for myself, just trying to practice what I preach. It's hard. I get it. It's a difficult thing, but I really think that's ultimately where we're limited in this category. Some patients we do end up sending on to a bariatric surgeon to help them before they have surgery. When we're dealing with multiple hip issues, it's very common. It's common for us to see, this next question says, can you have multiple hip issues? Yes, unfortunately, God never made a rule that we could only have one thing going on at a time. So I see multiple patients with hip problems and back problems, or hip and knee problems, or bursitis and a labral tear or arthritis. So sometimes we can treat one or the other. Sometimes we can treat multiple things at the same time, just depending on what they are. Recurrent labral tears, it's less than about 5% of the hip arthroscopy population. My current re-tear rate is right around 1 to 2%. And so when we look at that, patients do phenomenal, but yes, some people have recurrent tears or it doesn't heal all the way and can require more surgery. The next question says, what do you do to strengthen the SI joint which continues to slip because it doesn't hold in place? The SI joint's a really hard thing for us to treat. If we had a great treatment, there would be one recommendation and we would just fix it all the time. That's why SI joint surgery is really uncommon. It's a really rare thing to have SI joint surgery. There's not a great way to strengthen the joint itself. It's more about treating everything around it to try to make sure those muscles and the core, your back, and your hip abductor muscles are all real strong to try to help with that. The next question is, I have an issue with sleeping on my side for 6+ years, done PT with mediocre results. MRI and X-ray showed some arthritis. I was cleared for hip replacement in May, but postponed. I've started power walking, do 25+ miles a week since March, have had no pain while walking. Seems strange that I would need a hip replacement if I can do all these things with a problem without walking. I agree 100%. If you're not hurting and your hip's not keeping you from something, I wouldn't recommend a hip replacement. Everything changes when people are evaluated and when doctors see them, whether that's myself or anybody else. So we try to make recommendations based on what we're seeing at the time. Sometimes people prove us wrong. I don't believe in predictions a lot. So when some doctors say, hey, you're going to need a hip replacement in 10 years, I found way too often that I'm not good at predicting the future as far as how long it's going to go before somebody needs something else done. So I think it's great. As long as somebody can get relief without surgery, I always would prefer that option. So the next one is Andy from Select PT. And the question is, what do you recommend for treatment options related to chronic SI joint pain following a traumatic posterior? Sorry, I'm just reading through it. So when we're talking about traumatic injury to SI joint pain, when we look at the SI joint, again, with trauma, actually fusions end up being more common with sacral fractures or traumatic SI joint disruptions than when we talk about just regular SI joint pain. So often if people have continued SI joint pain, the best place for them to be would be with somebody that does SI joint fusions. Typically, that's one of the spine physicians. The last question I have here is, how does osteoporosis factor into any hip pain? When we look at osteoporosis, we use a DEXA scanner and look at osteoporosis a lot around the hip, mainly because people with osteoporosis are more likely to fall or suffer a hip fracture with a fall. And so that's why we kind of focus in on the hip with osteoporosis. The osteoporosis itself does not cause pain, but it does have your bones a little weaker where they could be more likely to get compression fractures in the lumbar spine, or if you had a fall, more likely to have a hip fracture. So while osteoporosis doesn't typically associate itself to pain, we treat a lot of people with hip pain that have osteoporosis. Typically, osteoporosis does not change what we can do for hip surgery. It may change some of the parts we use to accommodate your bone, but we often change our parts based on the patient to make sure we take care of each patient individually as best we can. Again, I thank everyone for their time. If there are any questions, we're happy to answer them. And our email is on this QRL code too, where people can get a hold of us. I'm gonna answer this last one and then we'll probably close this out. It says, outer hip pain at the top lateral iliac bone, worse going upstairs, getting up and down out of chair, pushing off with left leg. Please help. When I look at that, on the lateral side of the iliac bone and the outer hip, a lot of times I would start thinking IT band and gluteus maximus out in that area. And so I'd probably start there. But that would be something I would probably have to see. But a lot of all those descriptors are IT band related issues, with the pain just being a little higher at the insertion of the IT band.
Thank you, Dr. Ivie. If there are no other questions, we will wrap up. As Dr. Ivie said, you can scan the QR code and that'll take you to everything for him as well. But I will also be sending out a follow-up email. This presentation will be recorded, and I will send that out just for your convenience in case you want to go back and listen to anything. I will also send out a way to schedule. You can visit us at talkdocs.com and go to Dr. Ivie's website there to schedule. You can call us at 690-8461, or you can email us at feedback@talkdocs.com as well. Like I said, I'll send all this out in an email. If there are no other questions, we will wrap it up for the day.
Thank you everyone for taking time with us. Again, feedback too is how you like these talks. We've been doing this for TOC now for the past several months, and in the COVID era, we're planning to do this going forward versus our inpatient or in-person talks. So again, any feedback you have, anything that y'all would like to hear about or would like more information about, we can plan our future talks around that. And again, we appreciate everyone's time.
Thank you so much, everyone.